Sepsis is an ongoing challenge for hospitals to identify and treat. Mortality is high when sepsis progresses to shock and can be lowered with effective treatment early in the process. After working with my clinical contacts, conducting research, and working with other practitioners on my job, I developed a screening tool for sepsis which could be used in long-term care facilities. Though I was unable to fully implement the tool, it remains a viable option for helping identify possible septic patients for fast transition to acute care settings. The early recognition and treatment of the septic patient is vital for survival. Often, septic patients are seen in acute care settings with advanced illness. The earlier sepsis is diagnosed and treated, the better the outcomes. During my clinical rotation, I worked closely with a sepsis coordinator and the education director to develop a sepsis screen that might help patients be identified earlier in their disease process in long-term care facilities. The following discusses the needs assessment process and current research related to the project. Sepsis identification and early treatment have become a major goal in acute care settings. The Surviving Sepsis campaign was initiated in 2004 and updated in 2012 by 11 professional societies to reduce mortality from sepsis. Over 500,000 emergency department visits occur yearly due to severe sepsis, with a 28.6 mortality rate. The SSC standardized guidelines to be completed within 3 hours of ED admission include obtaining a lactate level and 2 blood cultures, administering broad-spectrum IV antibiotic therapy, and infusing a bolus of crystalloid IV fluid if a patient is hypotensive. Many hospitals have made this priority goal core measure by hiring a sepsis coordinator. Leslie Broman, RN BSN, is the resource nurse at Lewis Gale Hospital, Allegheny in Lowmore, Virginia. After spending time at my clinicals with Ms. Broman, I decided to work on an early sepsis identification tool which could be utilized in a long-term care facility to quickly identify and refer for treatment potentially septic patients. The hospital already has a standardized protocol for sepsis, so any project directly made for the hospital would not be able to be implemented. But if a long-term care facility staff could recognize sepsis before it progresses to organ dysfunction, mortality might be reduced. Thus, a tool which helps nursing staff recognize possible sepsis would prove an invaluable asset in the implementation of care. Once a patient is identified as having a positive screen, discussion must be initiated with the physician about referring the patient to a higher level of care. My objectives for this project included teaching nursing staff the definition and progression of sepsis, why early recognition and treatment is necessary for survival, what signs and symptoms are common, what the SSC recommends and why this impacts one's nursing practice. Once these objectives were met, a sepsis screening tool would be introduced which could be used by bedside nurses in the long-term care setting to improve patient outcomes. In order to develop a screening tool for nursing homes to use, I conducted research, including the databases CINAHL, Medline, and the Cochrane Database of Systematic Reviews. I used keywords sepsis, sepsis bundle, SIRS, protocols, mortality, sepsis alert, and surviving sepsis campaign in my search. I excluded pediatric patients, articles greater than 10 years old, and articles written in English languages other than English. Once the research was completed, I worked with the sepsis coordinator at Lewis Gale Allegheny to learn about their sepsis protocols and program, successes and challenges, and future goals. During my clinical rotation, we responded to 3 sepsis alerts. The coordinator worked with the laboratory, pharmacy, physician, and registered nurses to ensure the sepsis bundle was being followed. Per interview with her and reviewing the hospital's tool, I learned the protocols for this hospital. First, the triage time is recorded on a sepsis sheet. Next, the nurse determines if 2 or more of the following are present: a high or low temperature, respiration rate or heart rate, increased white blood cell counts, or decreased oxygen saturations. If so, lactate is drawn. If this is greater than 2, this is considered to be positive for organ dysfunction, indicating severe sepsis. High lactate levels are implicated in increased mortality for septic patients. Next, 2 blood cultures are drawn and IV broad-spectrum antibiotics infused. Finally, crystalloid fluids are given by IV bolus if the patient is hypotensive or has a lactate level greater than 4. A second lactate must be drawn within the 2 hours. This protocol is in line with the research. During my interview with the coordinator, I questioned how the physicians respond to the protocol. For example, if the physician believed a patient to be having acute on chronic heart failure, would he comply with the fluid bolus protocol? During this discussion, we went to the first sepsis alert and I was able to see the exact reaction I anticipated. The physician did not want to begin fluids or IV antibiotics to the patient who screened positive for the sepsis alert, but also had chronic heart failure. The sepsis coordinator continued to remind the physician of the steps needed to complete the bundle within the 3 hours. He did finally comply with the fluids and antibiotics, and within 10 minutes of the time limit. He discussed his belief that the diagnosis would not be sepsis, but heart failure, and he did not want to put more fluid on the patient's heart. She reminded him that the mortality rates from sepsis are high, and that fluid could be removed if the patient was truly not septic. By using both my research and the information I learned during my clinical experience, I worked on my sepsis tool for early identification for nursing home staff that would assist hospitals in providing appropriate care for good outcomes. The sooner sepsis is identified and treated, the better the outcomes. Sepsis is the body's clinical and systemic response to infection. The term sepsis is frequently used, however there are 4 distinct phases of sepsis per the research. The first phase is a systematic inflammatory response syndrome, or SIRS. In this phase, the patient will experience increased or decreased temperature, tachypnea, tachycardia, increased or decreased white blood cell counts, and altered mental status. This phase would be the best time to begin treatment before the patient moved into the next phase, known as sepsis. The septic phase includes at least 2 factors from the clinical presentation of the first phase, but also suspected infection. Treatment should be underway by this stage to reduce patient mortality. Although blood cultures might take 48 to 72 hours to reveal an infection, a broad-spectrum antibiotic will be administered per a sepsis bundle. The next phase is known as severe sepsis. In this phase, organ failure becomes apparent and a patient will need intensive care treatment. Organ failure will be organ-specific and discovered by labs and clinical presentation. Organ failure can occur in multiple systems such as renal, hepatic, respiratory, neurologic, and/or cardiovascular. The fourth stage is called septic shock. Septic shock occurs when fluid resuscitation is not enough to prevent hypotension, and vasopressors must be used to maintain pressure. This is the final stage and is associated with high mortality. Sepsis occurs when the body's immune system activates to fight off an infection source. This response activates white blood cell production and activity and causes vasodilation, clot formation, and cell permeability. It is important to control infection through strong nursing assessment for signs of inflammation. If the prevention of infection is not successful, by nursing interventions such as hand washing, oral care, etc. alone. Early ventilator weaning, use of inotropes and vasopressors, optimal glucose control, minimal use of sedation, short-term dialysis, and platelet therapy can be beneficial. Finally, the need to inform patients and their families within 72 hours of admission to an ICU setting of the prognosis for sepsis is necessary to develop reasonable treatment goals and manage expectations or initiate palliative care. To reduce mortality from sepsis, a severe sepsis bundle was implemented and revised in 2013 based on new research. The bundle gives time-specific protocols to follow at 3 and 6 hours. In the first 3 hours of suspected sepsis, the information we discussed earlier would be happening. We would get the serum lactate, 2 blood cultures, start IV broad-spectrum antibiotics, and crystalloid fluids if the patient was hypotensive or had a lactate level greater than 4. Serum lactate levels are used because they are positively correlated with patient outcomes. As discussed earlier, this is in line with the protocol used at Lewis Gale Allegheny. Further, a 6-hour bundle now includes placing a line to measure central venous pressure, using vasopressors if no response occurs from fluid resuscitation, and repeating the serum lactate level. These bundles have been found to decrease mortality, especially when the infection source is urinary. When sepsis is in the third and fourth stage, the mortality is 4 times higher if the infection source is pulmonary and vasopressors are being utilized. Increased BMI is a positive factor in reducing mortality as the patient has more caloric reserve. Initiating a sepsis and workup treatment protocol, or SWAT, has further found to improve patient outcomes. This protocol creates a sepsis alert and emergency room triages, which are activated by the EMR. It is apparent that nurses can play an instrumental role in preventing poor patient outcomes due to sepsis. Most research discusses nurses in the acute care setting, especially in emergency departments, ICUs, and med-surg units. Because most hospitals in the country are following these sepsis early recognition and treatment protocols, and with my long-term care background, I developed the following nursing tool for staff to better recognize SIRS and sepsis in the early phases in order to send the patient to a higher level of care for treatment. This slide shows my sepsis tool for long-term care nurses. As you can see, the directions state to use the following tool when you notice any change in your resident's mental status or condition, vital signs, or when you suspect an infection. Put a check mark in the correct column. If you check 2 or more columns with a yes, call your provider and tell them you have completed the sepsis protocol and it is positive. Per standing orders, written and accepted by the medical director, let the physician know that you're going to order the following stat labs and diagnostic tests: a chest x-ray, AP and lateral, CBC, serum lactate, and urinalysis with Coulton sensitivity. Initiate vital signs every 15 minutes as a nursing measure. If changes are noticed or the patient deteriorates, call the physician and send to a higher level of care. Using this simple screening tool can help alert a nursing home nurse that a patient might be septic. The earlier this is discovered, the faster the patient can be treated in the acute care setting. Nursing home staff are adept at noticing subtle changes in their patients as they see their patients every day. In order to implement this protocol at my workplace, I presented the current guidelines, discussed the importance of early recognition, showed how we could help with patient outcomes, and discussed how education could be given to our staff about sepsis and the new protocols. I approved this with the Director of Nursing, Administrator, and Medical Director. I worked with the Medical Director to develop the standing orders for labs and diagnostic testings. I originally wanted to initiate blood cultures and IV antibiotics with fluid administration as part of the standing orders. However, the physician did not want to include these initially, as he felt the patient should be seen in the acute care setting for this. He further discussed the fact that because blood cultures might be implemented before antibiotics can be given, as well as the time it takes to receive these results, communication breakdown could occur related to these results, and the hospital might not receive them from the nursing home. In the case the blood cultures were not known by the acute facility, antibiotics had already been administered, and the labs were redrawn, the results would no longer be as beneficial. Unfortunately, the Director of Nursing decided that she did not want to allow implementation after originally being supportive of the measures. She did not know how it could affect annual survey results from the Department of Health if the protocols were not followed properly every time. If the project could have been implemented as intended, the first step would have been to train the staff. Once that task was complete, the long-term care effectiveness would be unknown unless a study was approved by a research committee. The medical director revealed he thought the tool would be a useful addition to the facility's policies and procedures. He also agreed the tool could produce beneficial outcomes for patients and would be a cost-effective screening tool for skilled nursing facilities to use, which would be in line with the Surviving Sepsis campaign. I would recommend the screening tool to any long-term care facility, primary care office, or home health agency for many reasons. First, the tool is cost-effective. The only associated cost with it would be the hours needed to educate staff members. Second, the education is not difficult and can be completed within a typical in-service time frame. Next, physicians with hospital admitting privileges are already familiar with sepsis protocols and would be able to give patients faster screening with condition changes. Finally, patient outcomes are better with early sepsis recognition. Therefore, an early screening tool would only enhance sepsis recognition and early treatment. Educating nurses at all levels of patient interaction can help screen and refer possible septic patients for immediate treatment. outcomes would be favorable, and the hospital would have multiple community partners enhancing their sepsis protocols. Even though my tool could not be implemented, I think this tool, or one like it, could save lives. This slide shows the references that I used in my research besides the information that I was given at Lewis Gale Allegheny. Thank you very much.